Dear Chairman, thank you very much for the invitation, or dear group of Chairmen. I'm glad to be here in London, and I'd like to talk a little bit about LVRS. And as you know, as you see in the title nowadays, everybody's talking about bronchoscopic lung volume reduction surgery, but the surgery, and most of us probably are surgeons, is still fancy, let's say. And there is no conflict of interest, but to be honest, there is a little conflict of interest because I'm biased. I'm a surgeon, and maybe you know Zurich performs a lot of, or did perform a lot of lung volume reduction surgeries. So, and I'm a little bit skeptic still against those bronchoscopic things. We also consider, and to be honest, again, last year we did about 100 lung volume reduction procedures, and half of them were bronchoscopically and the other half was surgically, so it's equal now. Huh? But if you look at a disclosure slide of a pulmonologist performing those things, usually you see all brands like from valves, from coils listed up there, so they might be biased too a little bit. Okay. We all went through the same kind of education system as medical students, and I like question marks in a title of a presentation. It gives you at least the opportunity to have an answer, to have one take-home message in the end. And as we went all through the same education system, you all know very well the multiple choice question. So I'd like to go through this to get to this answer with a multiple choice question. And I don't know how you did, but I usually, if I had no clue, I sorted out the extremely wrong ones. So, you know, this one is wrong, this one is wrong. So the last one has to be true. And we want to do this right now. But like in a test, we should start with an easier question. First you have an easy question, then you have the difficult question. And the easy question here we'd like to go through is when is lung volume reduction, doesn't matter bronchoscopically or surgically, really indicated. And these are the answers you might see in patients with emphysema and severe pulmonary hypertension, emphysema and preserved diaphragma function, severe hyperinflation but only heterogeneous emphysema, hyperinflation despite emphysema morphology. And you all know already the answer, but I'll help you a little bit, and maybe we find one or another take-home message during this process. Of course, this is wrong. Severe pulmonary hypertension. Imagine asking your anesthesiologist to do major surgery in a patient with severe pulmonary hypertension except of transplantation and pulmonary endarterectomy. This is ridiculous. Although we have a few small papers talking about reducing the pulmonary pressures by lung volume reduction surgery. But these are small retrospective studies. So we agree with the emphysema, but severe pulmonary hypertension is wrong. It just should remind you that these patients are sick. They might have cardiac comorbidities, they might have pulmonary hypertension. Do stuff like echocardiographic screening, for example. Just keep in mind, these patients can be sick. But the answer is wrong. Preserved diaphragmatic function. Wrong. This is the key of lung volume reduction. You have a hyperinflated lung which pushes down your diaphragm. You see on the left side the patient before bilateral lung volume reduction surgery, on the right side after 3 months more or less surgery, this was measured by dynamic MRI. Diaphragm works better. This is old evidence, let's say. And this is the key issue of lung volume reduction surgery. Just resect or perform whatever to get an atelectasis. Just decrease the hyperinflation. The diaphragm comes up, and you get this result, and the patient is doing better. Huh? So we do not need preserved diaphragm function. Okay? This answer is wrong. So severe hyperinflation must be right, because I just said hyperinflation pushes down the diaphragm. So part of this important concept is the severe hyperinflation. So the last two answers, one of them must be right. Only in heterogeneous emphysema. This is actually a bronchoscopic study, the RENEW trial, and they nicely showed that patients with a residual volume higher than 225% had a much better result in heterogeneous and also in homogeneous emphysema than patients with a residual volume lower than 225%. So again, hyperinflation is the key. And always remember, patients who are symptomatic, who have a COPD, but are not hyperinflated, maybe a residual volume lower than 150%, for example, lower than 180%, they might have a sleep disorder, they might have a cardiac disease. They are not symptomatic because of the emphysema. So do not operate or whatever on these patients. Look at the residual volume, look at the RV-TLC ratio, also an important and good guideline to show you how the patient is hyperinflated. So severe hyperinflation, most important thing in lung volume reduction. Whatever you do, it's the hyperinflation. And we should still look at, is it only in heterogeneous emphysema, or should we not care about the morphology? I just give you a quick glimpse at the indication criteria. You all might know, but you know, optical medical treatment, symptomatic patients, of course, severe airflow obstruction, and this, I should have made it in red or something, but hyperinflation, here it's more than 175, RV-TLC ratio more than 58. This is the most important. The higher, the better. If you have a patient with an RV higher than 220%, you know you, not by 100%, but you know you will be successful after whatever you did, okay? Of course, absence of significant irreversible comorbidity like severe pulmonary hypertension, and use good imaging techniques, not only the CT. Try to include maybe a perfusion scintigraphy or a densitometry, something that shows you where are the target zones. This is important, and this is the whole stuff about lung volume reduction. And we all know, as the study I showed you, the RENEW trial, it even works in homogeneous emphysema. So it's not true only in heterogeneous emphysema. You also want to do it in, for example, purely homogeneous emphysema, because the concept of hyperinflation does also work in every morphology. It's not only the heterogeneous. We will talk about this later, because the heterogeneous morphology makes it somehow easier for the surgeon, but in the end, it's in patients with severe hyperinflation despite emphysema morphology. So this is the answer, okay? But now let's have a look at the main question in this talk. When is LVRS indicated in the current era of endo-bronchial therapy? These are the answers. Never, because they die. It's not a long time ago you would have chosen this answer. And B, only patients with homogeneous emphysema, only in bullous disease, always, because we don't have any good results from bronchoscopic lung volume reduction surgery, or preferably in upper lobe predominant heterogeneous disease, but evidence is maybe a little bit old and not that good as we got it in bronchoscopic lung volume reduction surgery. You all know the right answer already, but I will show you why the others are wrong. Never, because morbidity and mortality are too high. The whole fiasco started in 2001 when the NET group published their results, their preliminary results of only 69 patients who had a post-operative mortality of about 16%. And I mean, this was the title of this New England Journal of Medicine publication. And these patients had an FEV1 below 20% and a DLCO, diffusion capacity, below 20% or a homogeneous emphysema. Extremely high-risk patients. Even Zurich wouldn't operate on patients with a homogeneous emphysema, diffusion capacity below 20%, and so on. But to be honest, how do you read a paper? So a lot of physicians said, oh, England Journal of Medicine, people die after lung volume reduction surgery. So the referrals in a lot of centers worldwide, the referrals went down after this publication. But these were only the preliminary results they published 2 years before they published the real NET, the real National Emphysema Treatment Trial. So there it began. But if you look at the real mortality, the 90-day mortality, these were the NET patients, the good NET patients, the one with the heterogeneous emphysema, the one with a preserved diffusion capacity a little bit higher than 20%, 5.2. Other single-center series show this 90-day mortality. And here in New York, Ginsberg and his colleagues had a 6-month postoperative mortality of 0. So the mortality went down and isn't really an issue anymore. If you look at our own data, unpublished so far, but together with a few more now patients from New York, we had quite a few LVRS procedures, and they don't die anymore. Patients don't die anymore if you do it the right way. If they die, when they die, you're doing something wrong. So this is not the issue anymore, okay? They don't die. Forget this publication from 2001. We have now morbidity instead of mortality. And if you look at all the postoperative complications of these patients, they're almost insignificant. Pneumonias, empyemas, whatever, it's not really an issue. We talk about the prolonged air leak, which is in more than every third patient. This is the issue. This is the thing you should inform the patient before surgery, okay? So they stay quite a while, up to 10 days, 14 days in a hospital because of this air leak. In the United States, patients are kicked out of the hospital into a whatever nursing home, something. But this is what counts. It's the chest tube time and the prolonged air leak. If you look at the bronchoscopic studies, and let's have just a look at the valve interventions, which are good in heterogeneous emphysema, they produce, if they are performed well, atelectasis. And if you get a good atelectasis, there is a huge risk of a pneumothorax, right? And some people say if you don't get an atelectasis, if you don't get a pneumothorax, the valve treatment wasn't really good. So we have about 20 to 30% pneumothorax after valve treatment, which doesn't mean that it wasn't successful. Probably it means it was successful. But a lot of them produce also persistent air leak. So the main morbidity in lung volume reduction surgery is almost the same main morbidity as in valve treatment. Okay? So the morbidity and mortality issue isn't that important anymore. So the next answer, only in homogeneous emphysema. This is a typical example, first of a densitometry I would suggest to perform in every patient, because coloring stuff helps. We know this since we were childs. And in a homogeneous emphysema, you can do surgery because you want to reduce the hyperinflation. And a few years ago, my chief published something, and of course you don't get as good results as in heterogeneous emphysema, but it's still significant, and you can still help the patients. And actually, we have a delta of 36% in this study, and the 6-minute walking distance improved. Not as good as in heterogeneous emphysema, but it did. But this is the only existing study with lung volume reduction surgery in homogeneous emphysema patients. So unfortunately, we almost have to forget it. We do it, but you shouldn't do it because it's only one study and it's a retrospective study. But keep these, at least, these heterogeneous numbers in mind. This means about 120 to 150 meters. This is huge, okay? We keep this in mind. So we don't do it in homogeneous emphysema, lung volume reduction surgery, okay? Only in Bullo's disease. This is an example where every bronchoscopist would say, oh no, I don't touch, this is something for you, surgeon, do it. As you can see, there is no lung left. There are only bullae. And you might get concerned about, ooh, can I resect here everything? Because the remaining lung will be very, very, very small, and I'm a little bit afraid, but the lung will come back. Just resect the biggest bulla, and you will be successful. This is the same patient. This is intraoperatively before resection. Just focus on this. They will repeat 100 times the videos. This is the huge bulla. And the challenge here is not to resect too much. This is the result. And of course, we have a nice air leak here, which needed another wedge resection then. But this is the re-inflated lung. Very small. You see, air is coming back. There is huge residual space. But we keep calm, put in a chest tube, carry on. I mean, okay, you should close this air leak, otherwise the patient will stay forever in your hospital. But this was the day he left the hospital, 7th day. This was 3 months later. So one day we will plan to do the other side. But it works. It works. And nobody would discuss with you that this is an interventional case, okay? But I'm asking now, isn't there, not from a pathologic or histologic point of view, but from a surgical understanding, which might be a little bit simpler than the mentioned ones, isn't there some transmission from this bulla to the heterogeneous disease? And maybe in between there is this paraseptal disease, something, again, a pulmonologist wouldn't touch. Doesn't make sense to put valves in this lobe here, for example, or this. So this is also something you can resect. And here you can resect only the destroyed parts. And again, the classic heterogeneous emphysema also has some areas which are still good areas in an upper lobe, for example. But I will come back to this. So here we are going to call ourselves to do surgery instead of interventional therapies. Another thing, if you have a cancer or a nodule or something in a lung, and for example, this patient showed up with these values, FEV1 30%, diffusion capacity 14%, hyperinflation severe, again, this was a residual volume higher than 200%, but a good-looking target zone, okay? I mean, we did a segment sex resection. This was proven cancer, T1 and 0, and also a little bit more here to resect this hyperinflated area, and the patient improved. He didn't improve like, you know, from 30 to 34 or something like this. But this is still better than just watch and wait or do radiotherapy. I mean, this patient was referred from another center where even the radiotherapist said, oh no, we don't want to do something, okay? So this is also a good indication. And if you have still good tissue here, just do a wedge and maybe do on the other side the lung volume reduction. We looked at our patients, and only 14 patients, I know, but at least we had a significant improvement in this area, and they survived as they would survive without, for example, radiotherapy or something. And I mean, it's still better because you can maybe improve his dyspnea. So no, not only in Bollo's disease, always, because we don't have any good results in bronchoscopic lung volume reduction surgery. Bronchoscopic lung volume reduction, no, that's not true. We have good results. We have to admit it. And these are all randomized controlled trials, so good evidence, existing until now about coils and valves, okay? And these are the deltas in the 6-minute walking distance in meters, and in FEV1. It's not really impressive, okay? It's significant, and it's randomized controlled evidence. So good evidence, a lot of studies, new studies, 2018 Liberate trial, and but you know, the highest was 30%, and you remember the heterogeneous data I showed you. I know single center and not that good evidence, old stuff, but more than 50, up to 60%, 150 meters, something like this. So, you know, it's good evidence, it's randomized evidence, but yeah, we'll come back on that. So what about the long-term results? Because always, when they came up with their results, the bronchoscopists, and said, yeah, we have good results, and the only thing we need to do is a bronchoscopy, we always answered, yes, but you don't have any long-term results. So probably patient doesn't improve over years or whatever. And now, you know, we are all a little bit older, and the long-term results came up just to have shown it. This is the old, very good known long-term results. Here, for example, upper lobe predominant heterogeneous emphysema after bilateral lung volume reduction surgery in the NET trial. And they have a better survival. That we don't discuss about this anymore. They survive longer if you have a good patient selection and do the lung volume reduction surgery. So this is well known. But now, as I said, time passed, and now we have almost 500 patients after valve therapy, and they have quite a long follow-up, and they also realized, ooh, they survive longer if we do a proper valve treatment, here shown as an atelectasis. So again, the atelectasis is the key. Ooh, the atelectasis leads to pneumothorax. Ooh, the morbidity after bronchoscopic lung volume reduction is the same as after lung volume reduction surgery, just to say. But this is important. They have now long-term results. So again, wrong. So you knew it. We do take answer E, but it's not that simple. The evidence is old-fashioned because only one randomized controlled trial. This is the NET, very old, 2003, published. Lots of them were operated by sternotomy. And, well, we were not able to perform something else. Haven't been able since then, which is sad. But if you have a patient with this, and remember, you would do surgery in Buller's disease, you would do surgery in paraseptal disease, why wouldn't you do surgery in this classic upper lobe predominant emphysema? Because this you want to resect, okay? This is nothing. This is garbage, as you would say probably. And this part of the lung are way better, okay? Why would you exclude the whole lobe? This doesn't make sense, in my opinion, okay? So you take the upper lobe predominant emphysema, and you get fantastic results. I know, bad evidence, single center studies, old studies, but we have these results. This is the delta. And these are the patients who come back to your office and say, I can chop wood again. I'm working in my garden now. So they are happy, and this works. But just after the good patient selection. Yes, again, our data, even if you mix all them up, all morphologies, they improve after the surgery. And these patients profit the most with the upper lobe predominant emphysema. And then the question is, if you can offer this tailored treatment, why don't you offer it for non-upper lobe predominant disease? For example, here, don't put valves in this lobe, don't put coils. You know what happened with coils. Just resect it, okay? So we do it in the heterogeneous disease. We do it, to answer the question, in the bullous paraseptal disease. We might resect cancer as well. And this is something coming up, and also vice versa, maybe after unsuccessful bronchoscopic lung volume reduction. Thank you very much.